Presentation can be because of non-specific symptoms like fatigue, decreased energy, fever. Almost 60% of patients presents at with fever. Usually, parents take the children to the pediatrician because of fever. And once the peripheral smear is done and the diagnosis of leukemia is born out of that, that you have more than 20% of blast, they are cruising in the peripheral smear or in the blood. So from where the diagnosis is made, they went for a typhoid fever or dengue fever, and it turned out to be acute leukemia. Easy losing, bleeding, dyspnea, dizziness, infection. Coming to the joints, extremity pain in about 25% of patients and CNS involvement in 5% at presentation. Coming to the clinical examination, on physical examination, you will have a pallor, you will have ecchymosis, petechia, lymphadenopathy in almost 50% of patients, and which is contrary to the AML. In AML M4 only, you will have a lymphadenopathy, but in 50% of patients of ALL, you have a lymphadenopathy presentation. Hepatosplenomegaly in two-thirds of patients. Come to the lab investigations, anemia, definitely because of the marrow failure. WBC count may vary from hypo less than 100 to almost more than 1 lakh. So platelets are usually on the lower side. Thrombocytopenia is there. Increased LDH, increased uric acid levels. Chest X-ray may show a thymic mass in case of adult or in children T-cell ALL. And CSF should be done at upfront presentation because to evaluate the CSF involvement or brain involvement, which is present in almost 5% of patients. Hypercalcemia can be one of the presentation. Coming to the diagnosis, it's hematology, it's a immunohistochemistry, biochemical staining, flow cytometry, and cytogenetics. Coming to the blood, on peripheral smear, you can see that you have large lymphoblasts, which are in amongst the blood cells. And once a bone marrow is done, you will see large number of lymphoblasts encountering amongst the maturing lymphoid or other myeloid and platelet series. So on the right hand side, you will see a lot of lymphoblasts, which are large, circular, having multiple nuclei and intense basophilic cytoplasm. And on peripheral smear, you will see large lymphoblasts. Coming to the diagnosis is basically made on the basis of morphology and on the basis of the markers which it carries out. So FAB classification, which was born out of morphology-based classification, it is L1, small uniform blast, which is known as pediatric ALL. In almost 70% of cases, it is L1. In L2, it's a large, more variable size blast, which is more common in adults, almost 20% of patients. And it's L3 uniform cells with basophilic and sometimes bacular cytoplasm, which is mature B cell ALL. And sometimes Burkitt's lymphoma or Burkitt's leukemia is L3. So once it comes to your staining, in L1, you will have a pass positive. In L2 and L3, it is pass positive, it is peroxidase negative, and it is non-specific esterase negative. Now coming to the chromosomal or molecular abnormalities with prognostic significance in ALL. Better prognosis is once you have a normal karyotype or you have a hyperdiploidy. That means more than 56 chromosomes. Poor prognosis is with translocation. Since I told you that most commonest structure abnormality is a translocation. So the most translocations which are more common are carrying a very poor prognosis, or poor prognosis is translocation 814, translocation 411, translocation 119. And translocation 922, which is also positive in CML, it is carrying a very poor prognosis in ALL and AML both. So how to differentiate between AML and ALL? Coming to the age, I told you earlier also, AML is common in adults, ALL is more common in children. If coming to the blood, AML is having anemia, neutropenia, thrombocytopenia, myeloblasts, and promyelocytes in the blood. ALL is having large number of lymphoblasts and lymphocytes. Coming to the morphology, in bone marrow, AML blasts are medium to large with more cytoplasm, which may contain granules or rods, fine nuclear chromatin, and distinct nuclei. ALL blasts are small to medium with scarce cytoplasm, no granules, fine nuclear chromatin, and indistinct nuclei. Coming to histochemistry, IHC, if you go ahead with the AML, you have a positive peroxidase and Sudan black and negative TDT, that is terminal deoxy this esterase. ALL is having negative peroxidase, Sudan black, and positive TDT. Differential diagnosis is ITP, in which you will have only thrombocytopenia, no blast. Aplastic anemia, you will have a pancytopenia, but no blast, no spleen. Infectious mononucleosis sometimes represents cells which are typically looking like lymphoblasts, but it is a short-term increase, and with the passage of time, the lymphoblast or blast looking like cells decrease in the periphery. You have a fever, you have a viral like illness before starting with the peripheral smear having the lymphoblast like picture. Rheumatoid arthritis, you have joint pains, but Rh factor is positive. Rheumatic fever is commonly seen in right way. It's very going to be scarce now to see rheumatic fever, but typically you have a cardiology murmur, you have a mitral stenosis, or you will have a mitral regurgitation. It is having a syndrome complex in which rheumatic fever is diagnosed. Collagen vascular disorder like SLE, rheumatoid arthritis. So they also represents like, or even like autoimmune thrombocytopenia. So they also represents like ALL, but the commonest and most important differentiating point will be the presence of lymphoblast, either in peripheral blood or in bone marrow, more than 20%. So that stands the differential diagnosis of ALL. How to prognosticate in adult ALL? High risk features are age more than 35 years, WBC count more than 30,000, or more than 1 lakh in T cell subtype. While B cell disease is more, I suppose, it is more having more worse prognosis as compared to T cell disease. Philadelphia chromosome positivity, very poor prognosis. Translocation 411, 119, and complex karyotypes, that is having more than 5 chromosomal abnormalities. Low hypoploidy or near triploidy are also having a poor prognostic outcome in adult ALL. Coming to the risk stratification in ALL, you have three subtypes. Standard risk almost 65%, high risk and very high risk. Coming to the high risk, what are the high risk subtypes? Pre-B, Pro-B, age more than 35 years, WBC count more than 30,000, B cell subtype, more than 1 lakh in T cell ALL. And no remission after 4 weeks of induction, which is carried out by either a BFM 95 UK11 protocol. If after 28 days of treatment, your bone marrow is not in remission, that carries a high risk of relapse or progression of disease. Very high risk, if there is a positivity of chromosome Philadelphia positive, or it is positive for BCR ABL. So this similar prognosis is carries out in AML also, and it is a diagnostic feature of CML. But the difference is that in CML, you have a product which is known as P190. In ALL, the product is P210. So there is a difference of product, but overall the translocation is same, which is known as Philadelphia chromosome, or which is known as BCR. Coming to the treatment part, supportive care, as such patients will be anemic, as patients will be bleeding, they will have thrombocytopenia. So you have to support them with the blood care products like SDPs or with the blood transfusions. Coming to the most important part will be induction chemotherapy. So in many centers, you have different protocols. In my center, it carries out with the BFM 95 protocol, but the MCP 842 or MCP 841, UK 11, these all protocols are same, that carries the similar phases of induction chemotherapy, followed by consolidation, followed by reinduction and maintenance. Henceforth, it is only the physician choice, or it is the how the starter which is you are going to treat will be affordable or not, that will decide the subtype of induction chemotherapy protocol. But overall, with all the protocols, the remission rate is almost 60% to 80% in children. It is about 40% in adults. And the most important part will be hematopoietic stem cell transplantation, which has to be allogenic BMT if it is carried out in high risk and very high risk subtype of patients.